Our next speaker is Olivia Gosseries, who is a neuropsychologist and research associate at the Belgian National Funds for Scientific Research and a co-director of the Coma Science Group at the University of Liege in Belgium. And she will talk about disorders of consciousness. So over to you, Olivia.
Thank you very much, Andre, for the invitation. So tonight I would like to, initially I wanted to talk about disorders of consciousness and related states, but when I was doing my talk, I was thinking in half an hour it was better to focus on disorders of consciousness. So that's what I will do tonight. So first of all, who are we? So we are the GIGA Consciousness at the Coma Science Group in Belgium. And so the Coma Science Group was created by Dr. Stephen Lorace in 2007. And as you can see here, we are many people in the team, mostly physicians, neuropsychologists, engineers, computer scientists, biologists, physical therapists, speech therapists, and nurses. And we are all working together to evaluate the brain, and especially the lesion brain, so after a coma. So tonight I would like first to define you what we mean by disorders of consciousness, and then to look at what we do at the bedside. So how can we give a diagnosis of the level of consciousness when we see the patients? And then I would like to briefly explain you how we can use brain imaging to help with the diagnosis. And this is now more the work that I'm doing on treatment. So I will also briefly mention all the treatments that we are working on. And then quickly, the related research that we also do at the Coma Science Group. So first of all, what is a disorders of consciousness? What do we mean by that? So when someone has a severe brain injury, so that can be from traumatic or non-traumatic etiology. Traumatic is a shock in the head due to a car accident, for instance, or non-traumatic, so that can be an anoxia if you have a lack of oxygen in your brain due to a cardiac arrest or a stroke. Then the patient will fall into a coma. So what is a coma? A coma is an acute state. So you will only stay in a coma for a few hours up to a few days. After that, either you die because the brain lesions are too severe, or you enter into what we call a vegetative state, or now we prefer the term unresponsive wakefulness syndrome. So as soon as the patient opens the eyes, he's no longer in a coma. Okay, so this is very important. Then once this patient opens the eyes, then they recover arousal, but still they can still be unconscious and show only reflex behavior. So that's what we call unresponsive wakefulness syndrome. Then, once the patient recovers signs of consciousness, we say that the patient enters into a minimally conscious state. And this state has been divided in two categories, minimally conscious states plus or minus, depending on the absence or presence of language processing. So for instance, patients who are in a minimally conscious state plus, they will answer to a command, so they will understand. So they will have behavior that show us that they can understand what we are asking them. Whereas patients in a minimally conscious state minus, they show some behavior, but they are not related to language. So that can be visual pursuits or localization to pain, for instance. And as you can see here, this has been backed up by neuroimaging, where patients who are in a minimally conscious state plus, they don't have any hypometabolism in the left hemisphere. And that's where we have language area. Whereas patients who are in a minimally conscious minus, they have a hypometabolism, and especially in the language area. Then all those categories of patients, they have no communication. So it's impossible to communicate or to interact with them. Once they are able to communicate or to use functionally two objects, then we said that they emerge from the minimally conscious states. And then sometimes we have patients who, after a coma, enter into a locked-in syndrome. So I don't know if you know this condition, but basically they are fully aware and conscious, but they have no motor output. So they are paralyzed from head to toes. And here it's one example of a locked-in patient. And so you see that the only thing he can actually do and move is his eyes. He can blink and he can move his ocular eyes. And using his eyes only, he can actually interact with the world. And you see there is like a camera on top of the TV here. And these are looking at their eyes. And with that, he can select letters. And then to select a letter, he blinks. And then he does that letter by letter, and then words by words to end up with a text and sentences. So that's how patients with a locked-in syndrome can communicate. They cannot talk and they cannot move. And we can see here in the neuroimaging that what's blocking is that they have a section in the brainstem here that prevent all the motor fibers to go through the body. And so that's why they cannot move. And you can see here in blue, this is supposed to be red. So there's a hypometabolism in this specific area. So we do work with those patients as well. And then, as we have seen over the last decades, we have patients that we think they are unconscious, so they are unresponsive at the bedside. And yet, when we look at neuroimaging data, we see that they have brain activation that is similar to you and me. So that means they cannot be in an unresponsive state. And so for those patients, we have a new terms that we call the minimally conscious state STAR, or we can also use the cognitive motor dissociation. And there are many other terms that have been suggested for such dissociation between behavior and consciousness. And then I will explain you a bit more about that a bit later. So what the last things can tell us is that the absence of proof is absolutely not a proof of absence in our cases here. So I hope you were listening to me, because now I have a test for you. And I will ask you to tell me what's the diagnosis of the patients you'll see in the video. So the diagnosis can be a coma, unresponsive states, minimally conscious states, if you want to be even more precise, plus or minus, emergence, locked in, or MCS star. Are you ready? So here you can use the chat to tell me what you think the diagnosis is. Maybe you know her. Her name is Terry Schiavo. She's an American lady who had a cardiac arrest in the 90s, and she had very big media coverage because her parents wanted her to stay alive and her husband wanted her to die. And then it went to court, etc. And then at the end, they decided to stop the treatment, which means here to just stop giving her water and food. And then after 10 days of that, she passed away. So based on that, what do you think she is? What's your diagnosis? Someone say unresponsive, locked in, minimally conscious minus. Any other idea? Minimally conscious. So from 4 responses, you see that there's already a lot of different answers. So that proves that it's very hard to give a diagnosis just based on behavior. In her case, she was diagnosed as unresponsive state, unresponsive wakefulness syndrome. But that was back in the 90s. And at that time, we didn't have all these different classifications that I just gave you. So I personally believe that she was in a minimally conscious state. But to be more determined. So now, what do we do when we see those patients at the bedside? So how do we assess consciousness? There are 3 things first that we can assess. The first thing is arousal. Do they have eyes open or closed? Closed, coma. Eyes opened, more than coma. Then we look at awareness. What are the signs of consciousness? Is the person conscious, yes or no? And if we see that she's conscious, then the third thing we want to do is to try to communicate. And so to find a way to communicate with the person. So that can be verbally with a yes and a no, but most often it's through movement. So we will say to say no, close your eyes, to say yes, show a thumbs up. So that's the three things that we look at the bedside when we see patients. About consciousness, what are the signs that we are most often looking at? So based on the Coma Recovery Scale Revised, so this is a specific scale that has been developed to disentangle between unresponsive patient and minimally conscious patients. It has 23 items looking at audition, vision, motricity, verbal function, arousal. And then among all the things we look, there are actually 5 behaviors that are the most often observed in patients in minimally conscious states. The first one is a reproducible movement to command. So they have to reply at least 3 times out of 4 times to a specific command that we give. The command can be squeeze your hands, close your eyes, stick out your tongue, look up, etc. The second behavior is visual fixation. So they fixate an object or a mirror. The third one is visual pursuit. So either someone moving in the room, or we put a mirror in front of their eyes and then they look at the mirror or an object. And then the fourth one is localization to noxious stimulation. So we induce pain here, and then we look at the patient and he has to touch the point of painful stimulation to be considered conscious. And the last one is automatic motor responses. So that can be spontaneous, like I'm just doing now, like scratching my head or touching the tracheotomy or grabbing the sheets, etc. So that's are the signs that we will look at the bedside. But now we think that there are more signs, more behavior that could be considered conscious. And here again, I invite you to use the chat to tell me if you think of other signs of consciousness that we could assess in patients. I don't know if you have any ideas. I'll show you some, and then you can still type on the chat if you want. First one is that we believe is might be a sign of consciousness is resistance to eye opening. So some of our patients, they have eyes closed when we do the assessment, and then we try to open their eyes. And when we do so, they really resist with their, like this. And so this, we think that that might be a sign of consciousness. The second one is oral feeding. So we have noticed that there's almost no patients with unresponsive state who can actually eat and swallow food. So we think that to be able to swallow any food in an efficient way, you need to be conscious. A third one is sound localization. So if you hear sound and you turn your head or your eyes towards the sound, this for now is not considered as a sign of consciousness, but we actually have evidence that it might be considered. We should probably consider it as a sign of consciousness, like we do for visual pursuit or localization to pain. It's also a localization in other modalities. Then the work from the Paris team show that you can have if you have an auditive habituation reflex, then it can also be a sign of consciousness. So by repeating, by hearing something repeatedly, then you have a decrease of your startle reflex. And so that can be a sign that you are actually conscious. Then recently there was a suggestion that olfaction, so the fact that you breathe less when you smell something, might also be related to consciousness. However, if you blink to a visual threat like this, then this is not considered as a sign of consciousness. Another behavior that might be related to consciousness is leg crossing. It has been shown to have a better outcome, at least. And then lately, we're also wondering grimace. If someone has grimace and it's in a contextualized, maybe that can also be considered as a sign of consciousness. So that was an overall view of what has been done lately about research on behavior. And we have a recent recommendation from the European Academy of Neurology when you evaluate consciousness at the bedside. The first recommendation was to open the patient's eyes if they don't open it. The second one was to use a mirror if you want to assess visual pursuit, because you have more patients who will follow their own, they will follow their own eyes rather than a person in the room. The third recommendation is to use the full outline of unresponsiveness scale instead of the Glasgow Coma scale in the intensive care, because you can assess more signs of consciousness like the visual pursuit. And then the last two recommendations is to use the Coma Recovery Scale revised and to do it repeatedly, because if you only do it once, you may have a misdiagnosis just because the patient at that time was tired or sleepy or any other thing. So you must repeat the evaluation before you can make an accurate diagnosis. And then lately, we also have developed another scale, the second, the simplified evaluation of consciousness disorder. And this is because the Coma Recovery Scale, it's very long. The duration can go up to 45 minutes. And in the clinical routine, sometimes it can be impossible to do. So here we basically took the most important behavior and we made it as a new scale that is 2.5 times faster than the Coma Recovery Scale. So if you're interested, I can also show you, give you more information about that scale. And soon there will be a visual hands-on and more information about the guideline of that scale. So we've seen that it can be very difficult to assess behavior, consciousness with the behavior. So that's why it's important to also look at the neuroimaging. So in our centers and many other centers who are working with patients with disorders, we use the functional magnetic resonance imaging and the structural magnetic resonance imaging to look at the structure and the function of the brain, and more specifically, more the oxygens. Then we use the fluorodesoxyglucose positron emission tomography to look at the metabolism of the brain, so the consumption of the sugar in the brain. We also use high density EEG, and here you can see a cap of 256 electrodes that look at the electrical activity. And we also use the transcranial magnetic stimulation combined to the EEG, as Johan has already mentioned. So what did we learn looking at disorders of consciousness about consciousness? The first thing is that consciousness is not related to global brain function, or at least that was in very early studies in 2004. So here, looking at the brain metabolism with the PET scan, you and me right now, if you are still attentive to what I'm saying, we are in a normal consciousness, so we have 100% of brain metabolism. Someone who is brain dead will have no brain activation. It's the black box, as you can see here. And the purple is just the residual consumption of the tissue of the skin. Then tonight, when you'll go to sleep, you will have a 50% decrease of your brain metabolism. Then early in the morning, just before you wake up and you are entering into a rapid eye movement sleep and you're dreaming, then you will have an increased global metabolism. If you go under general anesthesia, you have again a massive decrease. And if you have a good anesthesiologist, after you wake up, you recover, and then you also have an increase of this brain metabolism. And then here we see a patient who are in an unresponsive state. So again, a massive decrease of global metabolism. And yet when that patient recovers, we see that it doesn't recover the full global metabolism. So this tells us that there's probably some area in the brain that are more important than others. And this is what we have seen, that the frontoparietal network seems to be more important for consciousness. Again, here, looking at the brain metabolism, we have seen that most patients who are in unresponsive states, they have a massive bilateral global frontoparietal hypometabolism. Whereas patients in a minimally conscious state here, you can see they still have hypometabolism in blue, but they do have some relatively preserved area, as you can see here in red, and this is in this frontoparietal network. So here we have a good distinction between the two based on the brain metabolism. However, we have also observed that 32% of patients who are unresponsive, they actually show a pattern like minimally conscious patients. So for those patients, that's the one we think they are in a MCS star or in a cognitive motor dissociation. Then we also observed that consciousness is not related to the activation of the primary cortices. And here it's an example with pain stimulation, but you also have this with auditory stimulation. So here, if I induce pain with like electrical stimulation on the wrist, you will activate in your brain the pain matrix, as you can see here in black. Patients who are brain dead, they have no brain activation. And then patients who are in an unresponsive state, you see that they do have some activation here in the primary cortex, but it's not connected to the other brain area. So it's not enough, we think it's not enough to be conscious. Whereas patients in a minimally conscious state, they do show this activation of this associative brain area, like people who are in a healthy control condition. So what else have we seen? That consciousness is also related to the thalamocortical loop or connection. And here it's an early study that showed that when a patient recovers from coma and recover consciousness, then he also recovers the connection between the frontal area and the thalamus. And similarly, if you implant an electrode in the thalamus here, and you stimulate the thalamus with this technique, deep brain stimulation, you will reactivate the thalamocortical system. And then this was a patient who was in a minimally conscious state. And thanks to that, he could recover and start communicate. And thus he was emerged from the minimally conscious state. So this is an important point too. Then more recently, we have seen that connectivity and functional connectivity and its dynamic into the brain is also related to consciousness. So you can use resting state fMRI, and here you have different brain network. The first one is the default mode network. So that's when you don't do any task and you're just like resting, mind wandering. Then you have the frontoparietal network. So that's more when the executive network, when you are doing something. Silence network related to emotion, auditory network, sensory motor network, and visual network. And you can see that all these different networks, they are actually related to the level of consciousness. So when you decrease the level of consciousness, you decrease those networks as well. Here in coma, you have nothing. In minimally conscious states, you do have activations. And similarly, you can look at functional connectivity using resting state electroencephalography. And here in particular, we are looking at the alpha band connectivity. And again, you see that you have a decrease of this connectivity in the brain according to the level of consciousness. Another point to look at is the top-down interaction into the brain. So this is also a more not so recent study, but important, where patients were listening to auditory tones, like an auditory oddball paradigm. And what we have observed using dynamic causal modeling is that when you hear a sound, it first goes into the auditory cortex, and then it goes to the associative cortex, and then it goes to the frontal cortex, and then it goes back. And the difference is that for patients who are unconscious, it doesn't go back. So it seems like this connection that is missing is the missing point of consciousness. So top-down connection seems to be important. And then complexity, brain complexity in the brain is also a concept that is important to take into account. And as Johan showed a bit before, but I'll show you again. So this is the work of Marcello Massimini's lab that we've been collaborating for many years. And so when someone is awake and conscious, again, like you and me right now, what happens is you stimulate the brain with the transcranial magnetic stimulation. And you see that after, if you look at around 400 milliseconds after the brain stimulation, you will have activation of the brain where you stimulate, but also everywhere else in the brain. And every line here is an electrode that we put on the head. And you see that every electrode will behave differently. Whereas tonight, when you'll go to sleep, this is what we will observe if we stimulate your brain while you're sleeping. This is a slow wave sleep, as you can observe spontaneously when you sleep. And what it does is, like, it still stimulates the brain, but it stays local. It doesn't propagate through the brain. And the response is way shorter. After 180 milliseconds, you have no more activation in the brain. So following that work, we also did the same in patients who had disorders of consciousness. And so we call it the zap and zip technique. You zap the brain with the TMS single pulse. You look at the brain response, and then you compress the information that you find in the response, spatially and temporally. And this gives you a number between 0 and 1. And in doing so, you see that participants who are awake like us, they always have a high PCI above 0.31. So each line here is a patient. Then we have stimulated different spots at different intensity, and every time it's above that threshold. But then when they go to sleep, you see that the PCI is lower. If you go under anesthesia with midazolam, xenon, or propofol, then again, PCI is low. And then we looked also at our patients, and we have the same story. In unresponsive patients, you have a low PCI. In patients in minimally conscious states, it's higher than the threshold 0.31. In patients who are exit from the minimally conscious states, and in patients who are locked in, you also have a high PCI. But then lately, we have observed that if we look at all the unresponsive patients that we assessed so far, some of them, they have no response. They have a flat response, so a PCI of 0. And this is often, or most of the time, patients who had anoxia, severe anoxia. Then the majority of the patients, they have these simple slow wave responses that we have seen just above, like sleeping. And then they have a low PCI. But then in some patients, we have a high complexity. So again, those patients, we believe that they are in a MCS star. So even if behaviorally we cannot see that they are conscious, they have at least in their brain the capacity to be conscious because they have complexity and a high PCI. And those patients tend to recover better afterwards. So I want to finish this section, just checking the time, to tell you another very important point that Johan already mentioned, is that consciousness is not the same as responsiveness. And here I have two clinical cases to really make that point. The first one, patient A, was a lady who came in Liege because she had a stroke 5 years earlier. And so she came for a week. We assessed her every day doing behavioral assessment. All the behavioral assessments said she's unresponsive, she's not conscious. Then we also looked at the multimodal imaging assessment. And what we see is when we look at the metabolism, she has a very severe hypometabolism. Everything is blue. We look at the resting state, here the default mode network. We see that there is no brain activation. we look at the structural MRI, so the diffusion tensor imaging, to look at the white matter track in her brain. And you see that it's very severely impaired, and there's lots of white matter track that are missing in front, mostly in front of her brain, but also on the sides. And then lastly, we ask her to do mental imagery in the fMRI scanner. So basically, we ask her to imagine playing tennis and to imagine moving into the house. And then those tasks will induce specific brain activation in the brain. And here we see that there is no such activation. So in her case, the brain imaging confirmed that she was unresponsive. And with the family, we discussed more end-of-life decision, because the husband told us that she didn't want to, they had previous discussion, she didn't want to stay in that state. Here we see that all the results are negative. She's been there for at least 5 years. So here we will more discuss, okay, if she has a complication or if she has like a pneumonia, then maybe it's better to not treat it and let her go. On the other side, we have another patient who had the behavior was exactly the same. She showed no signs of consciousness and she was considered as unresponsive by everyone. And yet you see here that the brain imaging is completely different. So first of all, we see that there is preserved metabolism in her brain, as you can see in green and in red. There is brain activation in the default mode network, at least on one side of the brain. Her white track matters are fully preserved. And when we ask her to play tennis or to move into her house, she actually did it because we saw those specific activation. So in her case, we had a complete different discussion with the family. First of all, she's clearly not in an unresponsive state, but in a minimally conscious state, star. And second of all, in her case, then we will more promote treatment, promote stimulation, and really try to find ways to communicate, to use brain-computer interfaces, etc., etc. So again, important, responsiveness does not equate consciousness. So how about treatment? So here we really had a big overview about diagnosis, but how about treatment? What can we do for those patients? So this is a model, the mesocircuit model by Nico Schiff, that will explain the different treatment that we are trying to test in that population. The first treatment that we can use is pharmacological agent using dopaminergic agents, for instance, so amantadine and apomorphine. Amantadine is the only actual treatment that has been recommended in America, but only if you have a traumatic brain injury and only if it's been between 4 and 16 weeks after the brain injury. It fasters the recovery of consciousness. Then we have the apomorphine that's been used for Parkinson's disease. And now in Liege, we are trying this treatment. And out of 6 patients, we do see an increase of behavior after 1 month treatment. And soon we will start randomized control trials to assess better this treatment. Then we have a GABAergic agent, the zolpidem, and I will talk about that a bit later, so I don't mention more here. Using brain stimulation, we have 3 kinds of approach. The first one is the top-down stimulation, and this is with, for instance, transcranial direct current stimulation or repetitive transcranial magnetic stimulation. Then we have the bottom-up stimulation that can be vagal nerve stimulation, vestibular stimulation, or spinal cord stimulation. And the third kind of stimulation is central. As we have seen, you have the deep brain stimulation, but you can also have this new technique, the low intensity focused ultrasound stimulation. So this is really an overview of what we have been using currently to try to treat coma. And then more particularly, I want to discuss the zolpidem. So I don't know if you know what zolpidem, or it's called also Ambien. I don't know in Oslo how it's called, but it's a sleeping pill. So anyone who takes that should go to sleep after 20 minutes. However, in 5%, and only in 5% of our patients, they wake up. So they have a paradoxical response. So some of them, they will be able to eat, to speak, to talk, but just for the time of the medication. So after 4 hours, they go back to their previous states. And what we have observed is when they are, for the paradoxical responder, when they are under zolpidem, what's different in their brain is that they have an activation or increased metabolism in the front of the brain, in the mesiofrontal area. And this area is related to motivation. So somehow they are just more motivated to show behaviors. And so now we wonder if we also have paradoxical responder in the general population. So I invite you all, but all, to fill our questionnaire online, a survey. And so first it's to see the prevalence, how many people have used this medication. And then among the ones who have used it, how many have experienced any paradoxical responses. So I would be very grateful if you can fill that survey. So in conclusion, we have seen that consciousness does not equate responsiveness, and at the brain level, consciousness equates activation of the frontoparietal network, and it's related to connectivity, to top-down interaction, and to complexity. For the diagnosis, we have seen that we have to use standardized scale, but we also have complementary tools using brain imaging and electrophysiology. Then we have quickly used that we are still working a lot on therapeutic interventions, and we absolutely need more randomized controlled trials and also just to try new treatments. So here in Liege, we will start psilocybin treatment. And then I would like to highlight again the ethical challenges while working with those patients who cannot give their consent, so we have to ask the family, and also to remember to don't judge a book by its cover, because we don't know what it's like to be in these states. So a few more slides. The first one is about near-death experience, because we have a team in our group who are also working on near-death experience after a coma, but also during general anesthesia, or can be in meditation or in sleep. So if you have any testimonies of people that you know have had an NDE, you can contact us at the email that you see here. And then we are also working on other modified state of consciousness, but again, I haven't had the time today to tell you more. And so we work on hypnosis, on trance, and more specifically cognitive trance, on meditation, on lucid dreamings, and also on anesthesia using the isolated forearm technique. And this, I will leave Katie to tell you more about this technique. So this I'll skip. And I thank you very much for your attention.